Nelson. I'm a registered nurse. I've been a registered nurse for more than 20 years. My whole professional life has been focused on providing direct patient care. I'm also the chair of MNA's Governmental Affairs Commission. Today, MNA is releasing new data on why nurses are leaving the bedside in Minnesota. But before we even get to the why, I really want to highlight one number, 2,400. That's how many MNA nurses left a bedside hospital job in the last year alone. That is a retention crisis. It means veteran nurses are retiring early, taking years of experience with them. It means new nurses are being turned away from a career they spent years earning a degree for, only to find out it wasn't what they signed up for. And make no mistake, there is not a shortage of Minnesotans who want to work as nurses. In 2022, there were more than 122,000 registered nurses in Minnesota, which is an increase of more than 4,000 over the previous year. Over and over again, in the responses submitted to this survey, we saw that nurses are saying that they miss the hospital. They never really wanted to leave bedside care, but the conditions that they faced there made it impossible for them to stay. In this new study, fewer than 1 in 5 nurses said they would not return to the bedside under any condition, which includes those who have retired. That means there are approximately 2,000 Minnesota nurses that are ready to return to the bedside if conditions improve. In the nearly 500 nurses that responded to the survey, the number one reason I identified for why they left the bedside was insufficient staffing, following by stress, management, and poor working conditions. These responses were mirrored when nurses were asked the top issue that needs to be fixed for them to consider returning to the hospital. Nurses far and away identified improved staffing as the most critical issue to nurse retention. We're here today not only to share this data, but to put faces and stories to these numbers. I want to start by sharing mine. While I'm still working as a hospital nurse, I can say that I have personally applied for over a dozen non-bedside positions over the last 5 years when I first started to seriously think about leaving the bedside. 5 years ago or so, the unit I was working on at the time merged with a different unit as a cost savings measure, and I was forced to learn how to care for a patient population that I was less familiar with and which had a much higher rate of poor outcomes, including patient deaths. So the patient deaths and the long-term health outcomes eventually really traumatized me to the point that I was crying in the bathroom at work and crying in the car on the way home. There was a point where I burst out into tears while I was providing chest compressions to a patient that was in a respiratory arrest. I wasn't given an option by my employer as to whether or not I wanted to continue to work on that unit after they made substantial changes. I wasn't really told what to expect, and suddenly watching patients suffer and die several times a week was not something that I was emotionally prepared for at all. When employers treat us as a number on a spreadsheet and say a nurse is a nurse is a nurse, we are left to either put up what we are given or leave. I was eventually able to find a new job that was a better fit for me. I did have to change hospitals to do so. But even in this position where I really love the work that I do, the effects of short staffing and unresponsive management have pushed many of my colleagues to leave. The actions of our employers can really make or break the will to stay at the bedside. Instead of working to retain us, we're being used up emotionally and physically. We're not really a billable line item like the hospitals can think we are at times. We are not robots. We're highly skilled professionals, and we are people, and we need to be treated as such. Nurses right now are fighting to pass the Keeping Nurses at the Bedside Act to solve the number one issue driving nurses away from our hospitals, which is the insufficient staffing that's enforced by unresponsive executives. So this new report that we have shows that improved staffing will retain nurses at the bedside and prioritize quality patient care throughout Minnesota. Now it's my pleasure to introduce the other nurses on our panel today. And after our discussion, we'll be glad to take a few questions from the press about this report and our stories. So I'll start on this end with Jean. So this is Jean Foreman. So if you could spell your name, please. Say where you worked before you left the bedside and what you're doing now.
Oh, thanks, Becky. And we work together, so I miss you, and my other co-workers as well at Abbott. My name is Jean Foreman, Jeanforman, and I actually retired in 2021. I retired early from Allina, an Abbott Northwestern Hospital, from the surgical pre-op post-op department. And should I go into everything?
We can run through the whole panel first, and then I'll come back to you.
Okay, great. So that's where my kind of basics start. Okay. Thanks, Becky.
Yep. Carrie, go ahead and share where you worked before you left the bedside and what you're doing now.
My name is Carrie Mortrud, CarrieMortrud, and I left an Allina facility, Abbott Northwestern, about in 2005, and I left because of staffing, and I became a lobbyist with the Minnesota Nurses Association, and now I'm the nurse staffing specialist.
Thank you, Carrie. Lisa, would you like to introduce yourself?
Yeah, my name is Lisa Sanford, Lisasanford. I was a bedside nurse in the pediatric intensive care of St. Paul Children's Hospital in St. Paul. And I now work for the Minnesota Nurses Association as a labor relations specialist.
Okay, thank you, Lisa. And Wendy Costello.
My name is Wendy, Wendy Costello, Costello, and I have been a nurse since 2001, making it a good 22 years of bedside care. I did retire in October of 21, and it was due to how we were being treated in the hospital and the short staffing. I am currently working voluntarily with community efforts to connect people with the follow-up care and barriers to care within my community. And I would consider going back to the bedside if I was convinced things had changed.
Thank you, Wendy. Let's talk about why we all individually left the bedside. Would you like to tell your story, Jean?
Sure. Thank you, Becky. Thanks, everyone. It's really good to be here, too. All right. I left in early 2021 after giving some thought during the beginning year of the pandemic, 2020. And at the time, I was a bargaining unit chair at Abbott, an elected steward, and also working then as a nurse in the pre-op post-op area. My duties as a chairperson had me representing nurses being called in for discipline, as well as meeting for grievances with the hospital over contract issues. I think that was a big reason I left, was these encounters with management and with the HR department. Really, the gloves started coming off during the pandemic, and the amount of disrespect towards myself as an elected union leader and towards the nurses who were involved in either a discipline or a contract dispute, like over a pay issue, seemed to be coming to a head in such minute things we're being hassled over. And I also felt that during my bedside duty shifts, when I was caring for patients in either the pre-op area, getting folks ready for surgery, or post-op, helping folks after surgery, the amount of gaslighting and disrespect from the managers over what was considered safe and what was needed each day in issues like PPE, that's our masks, gloves, and isolation procedures for folks potentially act with a positive COVID test and how we would proceed with them. And chuckling over that, well, we're 6 nurses short today. Ha ha ha. I did not find that funny. And I did not find solutions like do the best you can a very reasonable solution at a time when There was a lot of pressure for myself personally, I felt, to not become ill, and a lot of pressure to not contract COVID from a patient or potentially pass COVID to a patient. Because if you recall in 2020, we were still learning a lot about this disease. We did not have a vaccine yet. And we were also asked to come to our manager's office with our mask in our hand and show that it was broken or damaged in order to get a new one. We couldn't, as professional adult caregivers, decide that a mask no longer could stay on our face or protect us. The safety around that was very concerning. The ageism that I would experience as a union representative for senior nurses who were also concerned about their health and trying to understand how they could navigate COVID when being just a certain age meant that you had a more likely chance of contracting COVID. I felt no compassion towards these nurses from our managers or from our HR department. The amount of racism that I helped nurses of color navigate from patients, from our employer, from their colleagues, also met with, that's a you problem, not a us problem. All of these things caused me to just really take a step back and say, I can't keep doing this. I'm going to lose myself in this fight. I'm going to make a mistake caring for a patient. And I hate to say it, but having a day off almost made it harder because I didn't want to go back the next day. So over the holidays of 2020, I worked, with my family. I was, these are my prime earning years. I was at the top of the pay scale. I was practically at the top of the seniority scale. This is when I should be really making hay for retirement, for real retirement. And I said, I can't go on. And my family luckily supported me. So that was really super, because I felt like they were depending on me too. So I made that difficult decision, and I sent my manager a letter, in writing that I was retiring, and that was that. I never went back.
Thank you, Jean.
Yeah.
Lisa, I don't think I've heard your story. Can you talk a little bit about why you left the bedside and what drove you to leave?
Yeah, so probably one of the biggest passions that I had prior to leaving the bedside was I had to fight to save my unit. Pediatric intensive care unit in the heart of St. Paul is still at risk. It's a move that will reduce access of care by removing the PICU, but drawing patients to them with their new mental health unit, which is great. We're so glad they have that. But the fact is that the patients that come in through the ER sometimes sadly need the ICU. And their access of care is going to mean that they're going to have to get in an ambulance and go across to Minneapolis in order to get that. Families, and that's not just that population, it's anybody who walks into the ER and needs that level of access to care is going to need to be transported. Families that have financial barriers, language barriers, and also dealing with the panic, grief, and uncertainty are going to have to be uprooted and moved over into a different city. Those of us who care for these patients every day and know how quickly things can turn, how fast we need to respond, wrote letters, signed petitions, appealed to the board of directors, testified at the House and Senate Senate committee hearings, spoke to every city council member and Governor Walz about our concerns with this. We've been joined with physicians, families, community members. They continue their plans, but the logistics that we have all said make this decision infeasible is the only thing to slow them down. They persist because this is a financial position, placing profits over patients. This decision has chased out would-be lifers, such as myself, from the unit and made it difficult, if not impossible, to hire. I left because our concerns were not listened to, and we were seeing the result of that when these decisions came at the bedside. My final straw was when we were short. I was the one charge nurse working with one core nurse, and the rest were travelers and floats with extremely high volume and extremely high acuity. A patient came in extremely ill, needing several procedures in the ICU before going to surgery. And in order to do this, we had to shuffle patients. A float nurse who had never had this level of acuity had to take that patient. Travelers were unable to properly program meds on pumps. We were unable to set up equipment, leaving me to manage the tasks inside the room, as well as outside the room, such as coordinating the surgery that needed to happen immediately. Despite barriers, the team got the patient to surgery. I was proud of their efforts, and I made sure they knew that. A couple of weeks later, a charge nurse meeting was called, which was not a common occurrence. The manager called out the situation and myself by name and asked how we as charge nurses could better prepare the team for a rough admission. Asked if we were communicating roles and making sure that everybody knew what their roles were. She pointed out everything that was missed that day prior to and with no acknowledgement of the struggles that we overcame. Not once prior to the meeting did she have a conversation with me personally. My colleagues came to my defense and pointed out that it was staffing issues that even the most experienced of charge nurses would find difficulty overcoming. Once I left, I discovered I was also a burnout. As educator on the unit, in the beginning at least I had several new staff to onboard, as well as travelers that constantly rotated through. We were short on the unit, and I found it difficult to move shifts around, so I picked up extra to avoid further burden on my unit. And it left me working 45 to 60 hours a week at times. The worst stretch I worked was 7 on, 1 off, 4 on, 12-hour shifts. I did this many times. ER nurses are overrun. Nurses have been scheduled sometimes with 2 nurses on a unit working to 20 patients. They are facing a verbal, physical abuse with patients, with shortages that are, these shortages are new shortages are financially motivated and caused. They caused us to shift around patients and nurses that go in to feed this idea of a nurse is a nurse, which will take the nurses who are most skilled out of these roles and shove a novice in there who then just have to figure it out on their own. It takes the expert out of our expertise.
Thank you, Lisa. Wendy, would you like to share a little bit about why you left the bedside, what your shifts were like, what staffing was like? We are running just a little behind, so if we could shorten it just a
I
touch.
can do the clip notes.
Yes. Thank you.
It's been no surprise over the last, I would say, 15 years, there's been a general erosion of how we do what we can do for our patients, as well as an increase of acuity. That means all of the body systems, all of the things mentally, physically, that we need to take care of. They started taking away therapists and, oh, will you do this for us? They started taking away housekeeping and nutrition, and will you call that in? We have increased inclusion. I worked at Bethesda Hospital for 19 years. It was wonderful. Whoever came in, someone knew how to speak their language, be it a housekeeper, doctor, therapist. Someone knew someone from some country and they could speak several languages. And they felt at ease. Anxiety went down. And they were happy to be where they were. Let me tell you, people are not happy. We meet them at their crisis moment. And what do we meet them with? Our own crisis. And it is unsustainable. Our license is threatened daily. You've heard a number of reports about nurses that are being brought to court to be held liable for the accountability that should be on administration and has not yet come to fruit. I went from 8-hour shifts when I had to rebid from Bethesda to St. John's acuity versus long-term acute hospital. And I was used to very complex patients at that hospital, and it was a pretty happy moment for a brief second to just take care of one thing that one person wanted, treat them and put them back home, and they can follow up. But that's not what happened. 2 weeks later, we had COVID slam our hospitals and lack of PPE. I ran down to the emergency room. They were gracious enough to give us 3 bags. There were 0 gowns for us to go into anyone's room. We had 1 gown to last the shift, 12 hours before the next laundry load came in. We are held accountable for everything that goes wrong. They take the glory if anything happens to go right. It's celebrated on the backs of the people who work extraordinarily hard to make it. I got to the point where I had to take a little time off for family issues, and I found I could not go back. And it's not burnout. I am morally injured. It has been 2 years. I am still getting flashbacks of those incidences. I see those patients' eyes. They have not gone away from me, and they will not go away from me. We need to honor our commitment to do no harm, and right now, it's an open license on doing just the opposite.
Thank you. Carrie, can you tell a little bit about your story, what your shifts were like, and moving forward, what are you hearing about nurse colleagues that you have that are no longer working in the hospital? Why did they leave?
Sure. So I think you've heard from my colleagues up here that the pandemic just exposed what was already going on and exacerbated it, but I'm the story that can tell you that it has been an issue for a very long time. So in 2005 is when I actually left the bedside to try to make a difference and do something. I attempted other shifts before that. So I worked on a cardiac telemetry floor, so that was the step-down unit where we would receive patients for heart transplants or post open heart surgery. And the safe number, clear back in the late 90s, was about 7 to 8 on a night shift. And one night I had 12 patients assigned to me. So there was no cap on the amount of patients any nurse could be given. They just expect you to keep taking more and more and more. So I thought a solution would be to go to the ICU, where you surely can't have more than 2 patients, partly because the structure of the actual rooms. You can only fit 4 beds in those suites. And so I was assigned to a suite with 2 patients. My other 2 colleagues had 1-to-1 patients. And when I got the call from the post-anesthesia care unit that said, put your open heart patient in the hallway in a wheelchair with a heart monitor because we're bringing your next patient. That's when I decided this is not how healthcare is supposed to be. This is not why I became a nurse, to treat people like pieces of equipment that were just churning through a big factory. So I left to become a lobbyist, and I'm here to tell you that we're still working on this issue, and it hasn't gotten better, and as you can hear, it has gotten worse. And every time we hear, just work with us, just pick up the phone and call us when you need help. 90% of the time when nurses call their manager for help, there's either no one on the other end to answer the phone, they received a voicemail, or they're just told, do the best you can. And like Wendy said, it falls on the nurse delivering the care. We have no ability to stop the amount of patients that come in, but we're expected to care for more and more. And that doesn't mean I can split myself into 7 different nurses. I just have to care for that large amount. And so Becky, you asked about what else I've heard, and this just keeps happening. Nurses are leaving because they can't emotionally deal with the guilt and the fear every single day that they are not delivering safe care. They're not delivering good care that they were taught and trained they are responsible to give. So we have a duty to deliver safe care, but we don't have a right in the state, in the laws, to actually advocate for that safe care. And that's why we have to have something legislated and mandated, that there is a cap on the amount of patients that will be assigned to a nurse, depending on the specialty, where all the research has been done. We are not asking anyone to create new numbers. The research shows that the more patients get assigned to a nurse, the more mistakes, the more failure to rescue happens, the little tiny things nurses miss because they're so rushed over and over and over again. And Wendy mentioned it, Jean was mentioning her example as being a steward, having to represent more and more nurses because mistakes or pieces of healthcare were missed because we were given way too much at one time to take care of.
Thank you, Carrie. So for you folks that have left the hospital recently, Wendy, Lisa, Jean, what do you think the experience is like for new nurses when they come in? How do they? Have you heard from any of them? Have you talked to any of them?
Well, I was an educator in my unit, so
Seems
I'm
so lots of-
intimately aware of this. And it was a struggle all around. It was a struggle to find preceptors because there weren't enough experienced nurses. I would have to figure out first who was available to be charged, and then who had the skill to orient that nurse. When I did find those people, a lot of times there was a shift because they needed the one experienced nurse left to take the sickest assignment that was too much for the orientee. A lot of times we had to double up assignments so that it would be team nursing, essentially. So you would have the orientee and the preceptor doing what was too much for one nurse, which is not a good learning environment. We sometimes had pressure on us, like, she can come off orientation, right? No, she can't, because she has not had the experiences that we have agreed they need to have before they come off. They're not getting those done. The preceptor, myself, and the new nurse say, I am not ready. I have not had these experiences. I have not had the time to struggle and work through these because we don't have the time to talk through it. So they feel unsupported. And unfortunately, like, I've had some nurses that have not made it through it. And one is thriving now because she found a better spot where she was more supported because they were on a better staff unit. And now she's great. But we could not provide that for her. And it is unfair to new nurses. And we've seen those new nurses say, this is more than I thought it would be. We can work through that a lot, but if we don't have the resources and the people who can sit and teach them, then they leave. They say, this is too much. This isn't what I thought it was. And then they leave.
For me, right after I retired, I had a number of new nurses, someone 1 year or less. They toughed it out up to a year, some of them. They're all pleading, how can I be a nurse and not have to deal with this? And it was coaching them in, well, what were your interests when you started to be a nurse? And this is, go to a specialty, or do you really need the pay? Do you really want to be a hospital nurse? There's other types of nursing. They're grossly underpaid, and you still have to work extremely hard, but you don't have that acuity, that life and death moment. And they all have opted to move out of nursing and do a different, lower form or lower paid of nursing. I'm not going to disrespect any form of nursing because everything's required when you come to be a school nurse or a parish nurse or a community public health nurse. I can't emphasize it enough. We're scaring away the most trusted profession. And the demographics right now with more and more elderly, more and more people who are injured or sick chronically early on, who's taking care of them? The barriers have gotten higher and they are not being attended to. It's just being shoved under the rug and it is coming to a crisis point. We need everyone's public voice to tell our legislature we have the right for care. And this is only thing I think that will really help, is getting the public's support in what their needs are. Thank you.
Thank you, Wendy. So shifting to the hospitals, let's talk about hospital executives and the hospitals themselves. So executives are saying that there aren't enough nurses who want to work. What do folks think about that are on the panel? And what do you think would need to change inside the hospitals for you to have stayed at the bedside? Can you use some microphone?
Becky and everyone, thanks for this question. You know, you let me know that you were going to ask this question. And, you know, first of all, my, smart mouth answer is nurse execs or hospital execs, why don't you cut your pay and double your work? That might help. But realistically, I think something that would be important would be, why can't we have a bedside nurse on your board of directors? Why can't we be where decisions are being made to tell folks what is going on? The board of directors on most healthcare organizations, to me, seems like a feel-good, money laundering, well, not money laundering, but money exchange place where favors are done. And what's needed for community care, what's needed for patient care, I would really question if that's happening, but I wouldn't know because I can't go to a board meeting. And a staff nurse isn't invited to those spaces. You need to listen, hospital executives, you need to listen to nurses. I just went to a strike, a picket line, wasn't a strike, but a picket at SEIU the other day. When there are folks out on the sidewalk, when it's 25, 30 degrees out, please listen to your staff. Listen to your staff. They don't have contracts. They want to take care of patients. I heard from lab techs, phlebotomists, they don't have enough help. They don't have enough equipment. And those are the folks that support this group in doing their job to get people well. I have to know that a lab is drawn at the right time into the correct tube and result it back to me in a proper amount of time. I can't go down to the kitchen to get food. It's just ridiculous what is being asked with especially at Abbott there's cranes, there's shiny new construction going on. What is going on the inside? And I would say that this is probably a good reason why I left. I can be a better patient advocate now outside of the walls than I ever could be inside the walls. Because I can say things now that won't get me fired. To be very honest, I won't get fired for saying you're not doing right by your staff. And when we say nurses, we do not mean, unfortunately, nurses in management. We mean staff nurses. So please don't confuse the two. When they say we have nurses, there's a nurse who works in the HR department who hasn't practiced nursing, but in times of labor strife, she is a nurse. That is troubling. So you listen to that person, but you won't listen to your staff. That's what hospital executives can do. They can listen to staff nurses, physical therapists, lab techs, the people doing the work of providing care in those patient rooms. Listen to the staff.
Thank you so much, Jean. We are probably over time now, but we can take some questions from press if they have some for us.
I'm hoping you can respond to the Minnesota Hospital Association. They just put out this press release talking about, they were saying, this legislation would reduce hospital care capacity by 15%. What would you say in response to that?
I would like to know really how they arrived at that number.
Yes.
We very rarely see patients that are turned away from the hospital, regardless of staffing. So I frankly just don't believe it. I don't believe that they won't be able to somehow get those patients in those beds, because they always do, they always have.
And Becky and all, I think we would agree, where's the survey to find out how many patients are not actually receiving care that are already in the hospital?
True.
There are so many patients that get admitted and they're in now a hallway bed with no call light, no privacy, no way to actually receive care. And so how about you look at how many patients are already in the hospital not receiving care, let alone the quality of care that they should be getting.
That's right, and the legislation is in the hopper. It's not even law, and patients are in hallways. Hospitals are closing already. Units are closing. In 2020, when I, again, represented at Abbott, we closed an outpatient mental health unit. We closed and reduced care for home health to obstetric patients and postpartum patients. We reduced those things. I had to navigate layoffs of qualified nurses. And again, what was the answer? It's been said how many times here? Well, a nurse is a nurse is a nurse. Just go to a different department, you'll still have a job. But the job that brings you life, that brings your passion and care, commitment, expertise, is gone.
Right. So, I mean, that's really our response. I mean, the situation is such that care is already being reduced. This is happening in greater Minnesota. It's happening in the Twin Cities. We can all talk about units that have been closed, entire hospitals that have been closed in the middle of a pandemic, obstetric services being reduced, outside the metro area, so folks have to drive 50 miles to have a baby. These things are already happening. The hospitals cannot turn around now and say that, oh, we are concerned about beds, because they're already closing beds. That's the reality.
To add my 2 cents. There are patients that are suffering severe heart attacks. I know of one personally who had to wait 12 hours in an ED that was overrun with COVID at the time, had nowhere to go. 12 hours later, he had to share a room with a psychotic withdrawal druggie. He's having an active heart attack. He had to move to another room. He also shared. This guy was in a coma. He said, what, I'm supposed to die? And then finally, he was able to get his surgery. 5 stents. It was a delay of care. Another patient, elderly, he went into the emergency room. He was sent home to set up his own appointment with a GI doctor for a partial blockage. He called his doctor who knew him well. Took her 5 days to find him a bed. We got him there, and guess what? It was complete blockage, but they couldn't clear it. Why? It was a delay of care. Delay of care, and those are just 2 stories I know of. Everyone knows somebody who's had delay of care, and they're so grateful when they get in. But are we at that point? Do we want that type of care to continue? I would vote no. And what I hear from my fellow nurses, no. And from your faces that I see, no. We can provide the care. We have the ability to provide the care. We need to get the administrators to sign on to, we're here to care for you. Right now, they're not.
Delay of care, poor quality of care, patients left without being seen. We're telling you that these are all a result in the nursing flight, right? It's all a result in short staffing. What we're also telling you is that this bill that we're pushing to keep nurses at the bedside is to keep nurses at the bedside. And that's going to be the solution. So it needs to be figured out, because part of that loss in revenue is the fact that you have increased nosocomial infections, right? Mm-hmm. Increased infections that they don't get reimbursed from. That has to be, it's a result of us not being able to do our jobs to the best capacity. Wounds and things that happen when we are too short to do the things that we need to do. They can't afford not to support this bill.
Other questions?
There is an editorial in the Star Tribune this morning that talked about the financial situation at Minnesota hospitals, which is something that's come up a lot over the past few months, and it certainly came up during negotiations. I'm curious, one of the things they say the state should do is provide some funding for hospitals to address some of those cost shortfalls. And I guess I wonder, we're talking about the Keeping Nurses at the Bedside Act. This would be different funding. Is that something that y'all would support? Is a grant program that would help with what the hospitals say are these budgetary challenges they're facing?
Do you want to, I don't think we have a position. You want to answer?
Yeah.
I thought we lost you.
There's somewhere. Yeah.
Go ahead.
Of course, we would support money to help with this in any way. As Jean Mill pointed out, is there are big shiny cranes and all kinds of stuff going on that we already question, where did that come from, right? And so if it's about patient care, then let's deal with the patient care and get things fixed inside before we start looking at all the flashy new things we can purchase and build and buy and draw attention.
Yeah, I think there'd have to be a lot of guardrails on that, personally. If it's the same as the reinsurance plans that insurance companies have gotten, where the cash is just handed over and very little, accountability and oversight is provided, so that you get bang for your buck as a taxpayer, I'd be concerned. Like, what is the money for, and how are we going to measure the success? I'd be concerned about that, because I believe a lot of hospitals, if I can recall back, got PPP loans during the pandemic and are still operating at losses and saying they have, especially we just had a contract last year that we have no money to pay nurses. I'm just getting confused, and that's why, again, I think there should be staff nurses on the boards of directors.
I have a tough time knowing what to believe. When you go to a town hall meeting or a mandatory meeting with the administrators and they explain what our goals are for the following year, And they're saying, you got to do more with less. You got to do more with less. We really can make this happen. It's so close. And then you go to the shareholders meeting and you're invited when you've worked 10 years, 15, 20 years. You're invited to go to these. And everything's magically better. It's like, just skip the facility meeting and go to theirs because the returns are great. We're doing better than ever. We're the last ones to hear that. So who's really struggling? They have different funds for strike funds. They have different funds for the general fund. And they have a different way of doing the books, I believe, to tell us that we are not enough. What we give is not enough. And so I have a hard time believing it.
Thanks, everyone.